Greetings, this is Miss Gibson. So the next lecture we're going to be doing is acute injury and chronic kidney disease. Acute kidney injury is the most common. This can be caused from medication, it can be caused from UTIs. However, the acute and the chronic, they both require replacement therapy like dialysis. With end-stage kidney disease, dialysis or transplant is the life-saving treatment. With end-stage kidney disease, the patient has a reduced quality of life. When kidney function is suddenly disruptive, acute kidney injury is diagnosed. This can be temporary or it can progress to that chronic kidney disease. Acute kidney injury, or AKI, you might see it in literature, is defined as an abrupt or rapid decline in renal filtration function. Make sure you know what this oliguria and anuria is. We've talked about them prior, but make sure you know what that is. The longer the time of decreased urine output or no output, the less likely the patient will return to baseline function. So that's very important to know. Acute kidney injury causes pre-renal. This is an adaptive response to severe volume depletion or hypotension with structurally intact nephrons. So that means it's happening before the kidneys, which is also the most common cause. The next is a response to cytotoxic, ischemic, or inflammatory insults to the kidneys with structural and functional damage. The post-renal, this is from obstruction. Think about the obstruction lecture that I done, which could be from kidney stones. Think about some of the other obstructions. The pre-renal volume loss can provoke this syndrome. Let's see, what else do we need to talk about? Diseases that decrease the effective arterial blood volume includes hypovolemia, heart failure, liver failure, sepsis, anything that can cause vasoconstriction, which can be like your hypercalcemia, drugs such as NSAIDs, norepinephrine, some of your radio contrast agents, some systematic vasodilation can also cause sepsis, anaphylactic shock, drug overdose, anything that can cause decreased cardiac output, heart failure, pulmonary embolus, anything like that can cause that pre-renal before the kidneys. This intrinsic, this is something that attacks the organ. This can be a structural injury in the kidney, which is the hallmark of intrinsic AKI. It's ischemic or cytotoxic. It can be renal artery obstruction, renal vein obstruction, microangiopathy, which is just where the you may have preeclampsia, the you may have the preeclampsia, which can cause that obstruction. Malignant hypertension, which is that really high hypertension. Even transplant rejection can cause this intrinsic AKI. Let's see, your glomeruli can cause a disease that's called antiglomerular basement membrane disease. It's part of the Goodpasture syndrome. Make sure you look at the resource that I have up on it. It's a very interesting pattern. Cytotoxic etiologies can be that rhabdomyolysis, could be tumor lysis syndrome, seizures. There are several drugs like lithium. And then, of course, your radio contrast agents can also cause that intrinsic. Your post-renal, this is any kind of mechanical obstruction of the urinary system, including the renal pelvis, uterus, oh my gosh, forgive me, uterus, bladder, and urethra. Results in obstructive uropathy and post-renal AKI. So stone disease, strictures, fibroids, bladder neck obstruction, urethral obstructions, intra-abdominal hypertension, renal vein thrombosis, disease causing urinary obstruction from the level of the renal tubules to the urethral opening. With perirenal and postrenal pathology, the kidney compensates by 3 pathways. Number 1, it constricts the kidney blood vessels. 2, it activates the renin, angiotensin, aldosterone pathway. And then lastly, it releases ADH, which is antidiuretic hormone. These responses help to improve kidney function, but it can also reduce urine elimination, which results in oliguria. Timely removal of the cause of AKI is the best way to prevent further progression to end stage. Then, of course, your assessment, which we've gone over. Do good health history, physical assessment head to toe. All of your labs and imaging will also need to be monitored. Your intervention, you want to avoid low blood pressure, reduce exposure to nephrotoxic medication. Early identification is always the key. Some of the nephrotoxic medications, if they're on those, you want to monitor their labs. Let's see, which would be your BUN and creatinine. Make sure that you look at the resource that I'm going to have on there on the nephrotoxic meds. I'll make sure and put that extra resource on there. Chronic kidney disease, this will require dialysis and kidney transplant if they can, if they meet all the criteria for that. It is progressive and irreversible. Here are your body changes. With chronic kidney disease, this means your kidneys are damaged and can't filter the blood the way they should. It's called chronic because the damage to your kidneys occurs slowly over a long period of time. It causes waste buildup in your body, can cause other health problems. Metabolically, urea and creatinine excretion are disruptive, so we know that creatinine comes from proteins in your skeletal muscles. In early CKD patients, they are at risk for hyponatremia due to decreased healthy nephron. The nephrons don't work like they should. Then as it progresses, sodium increases because urine production is decreased. And we know that sodium retention can cause high blood pressure as well as edema. Potassium excretion is normally done by the kidneys. With later stage CDK, increase in potassium is possible. which can lead to cardiac arrhythmias. Your acid base changes in the early stages, blood pH is not affected. As more nephrons are lost, acid excretion is reduced, which can cause metabolic acidosis. As CKD worsens, acid retention increases, so respiratory action increases to help pH normal. We know that the respiratory system compensates for the increased hydrogen ions by increasing the rate or depth of breathing to excrete CO2 through the lungs, which is called Kussmaul's respirations. Your cardiac, of course, you're going to have high blood pressure. They can be, they will be anemic because the kidneys manufacture a hormone called erythropoietin, which tells the bone marrow to make more red blood cells. If the kidneys are damaged, your erythropoietin levels can fall and your body will not make enough red blood cells. Blood and immunity. Having a kidney disease or kidney failure can weaken your immune system, which makes it easier for infections. In fact, doctors and researchers have found that most infections, like those caused by pneumococcal disease, are often worse in people with kidney disease. With anemia in CKD, the kidney don't produce erythropoietin, and thus reduce RBCs, which can result in low iron as well as folic acid may be impaired. Gastrointestinal changes described as fishy uremic breath is usually considered a consequence of increased salivary ammonia. Uremic stomatitis is characterized by a coated tongue, which is usually coated white. Painful ulcerations of your mucous membranes, and a metallic taste. Nausea, vomiting, and hiccups are common in your CKD patients. Peptic ulcers are also very common, and uremic diarrhea is also common in your CKD patients. Your health promotions, I'm going to let you guys read over that. Make sure you look at the renin, the angiotensin extra resources that's going to be on Blackboard as well, because they will use an angiotensin converting enzyme inhibitor, or ARBs, in patients with proteinuria. Avoidance of nephrotoxins, which is just your contrast media, and NSAIDs are biggies. Your assessment, we know we're going to do head to toe, height, weight, ask about medicines, any past histories, family history. So here's your management techniques, what you need to look for all those things we discussed here. Once again, if you have any questions, please email me. If I've confused you or you find that I've misspoken, please don't hesitate to let me know. We're in this together. Thank you.